Hi everyone. So the topic of bariatric and metabolic surgery. It's still one of the most controversial of all topics in general surgery. Why? Because there has been a wrong perception in the whole world about bariatrics being a cosmetic surgery, and the indications and guidelines are not very clear to the common public and even to some of the medical fraternities as well. So, this is very important to understand certain principles and practices in bariatric and metabolic surgery to be able to successfully convince the whole world that this is a metabolic gastrointestinal surgery and not weight loss cosmetic surgery alone. Having said that, let's talk about why is this hue and cry about bariatric surgery being so controversial in the last couple of decades, especially in the last few years, because of the global epidemic of obesity. The whole world is reeling under obesity pandemic, especially in the last year of COVID-19. There has been a study which said that there's a 20% increase in the body weight of individuals because of COVID-19. So the 2015 WHO source is the last source of the whole world's population and their weight uh, assessment showed India to be in the range of 21% of the people reeling from obesity, which in 2019 was estimated to be close to around 28%. So it's fast growing. The same way the whole global epidemic of obesity is fast growing and which causes a lot of trouble. That's the reason why we are speaking about bariatrics here. We call India the prosperous India of late because not of just of the economical side, but also from the weight side. The population of India is growing as well as the obesity and the metabolic syndromes. India is now the second biggest population of diabetes, second biggest population of hypertension, and is the highest percentage of death due to obesity in the world. That's a very dangerous situation what we are facing here, and very diverse. 25% of population is obese, 25% of population is malnourished. This kind of scenario is pretty bad in our country. And the worst is in the top 10, all the four states of the south are there. You see, Andhra Pradesh is number one, then we have Kerala number four, we have Tamil Nadu number six, and Telangana number seven of the top 10. That's not a great sign when the four states, because I think we are more carbohydrate based and sedentary lifestyle players in the country and facing obesity as a big problem. In the last decade, states like Goa, Madhya Pradesh, and Meghalaya are also adding their tally to the obesity epidemic with more than twice the amount of people becoming obese, which is again an alarming situation. When it comes to obesity, we have to understand certain things. It's not just the scale or the weight in the weighing scale only. It's about various parameters. It's our metabolic rate as a link to obesity, percentage body fat as linked to obesity, and skeletal muscle mass as a link to obesity. You see this picture, a BMI of 31.7 in the both the sides, a Caucasian on the left hand side and Indian on the right hand side. The percentage of body fat, sorry, Indian on the left side and Caucasian on the right side. An Indian man has a more percentage of body fat and less kilogram of skeletal muscle mass than the Western population. So we are prone for 20% less muscle mass and around 30% more fat mass than the Westerners for the same BMI. And this is one main reason why we are more prone to metabolic syndromes than the Western population. And that is why it's more important to Indians and Asians to be on the fitter side. And that's ugly truth. As I told you before, second highest diabetic country in the world, third most ranked cancer country in the world, and more than 30% of the cancer are obesity related. 7 to 10 years loss of disease-free life because of obesity, and second most hypertensive country in the world as well. 29% higher risk of premature death. That's pretty high. Close to 30% of people die earlier than they are destined to when they have obesity. And of course, life expectancy comes down by 10 to 15%. And second most common cause of death beyond tobacco. Why we talk about bariatric surgery big way is the reason is this. It's a very interesting study by IFSO APC in their consensus statement, because bariatric surgery is the only proven life-saving modality when other modalities have failed. The conservative methods of lifestyle changes, medications, exercise, and all those things have failed. Bariatric surgery is the only proven way for a long-term weight loss and long-term resolution of comorbidities. And this is supported by a study by Nicholas in his 2007 meta-analysis of larger population of 1 lakhs of people, where the 5-year mortality of people who underwent bariatrics and people who underwent lifestyle and medical therapy were compared. The mortality rate at 5 years was 6.17% if the patient undergoes lifestyle modification, 0.68% if they underwent bariatric surgery. That's a beautiful article which opened up the floodgates to to popularize bariatric and metabolic surgery around the globe. Going back to history, in 1954, Kremer is the first one who started a gastric bypass. So he didn't do any reduction in the stomach. He just do intestinal bypass to the stomach and try to help with the weight loss. Yes, there was weight loss, but there are a lot of nutritional deficiencies and a lot of bacterial colonization and other things and indigestion, diarrhea, plenty of issues happened. Then 1963, a jejunocolic shunt or called intestinal bypass was done by Payne, Devine, and Commons, which it had a lot of detrimental effect. So it was abandoned quite a few years itself. And in 1967, Mason tried the first mini gastric bypass. Instead of a sleeve gastric uh, pouch, he did a transverse pouch, allowing the whole of the fundus on the body to be available for the stomach in the bypass. This, like a 1954 bypass, had some issues of digestion, diarrhea, nutrition deficiencies all put together. Then in 1882, vertical banded gastroplasty was started by Mason again, uh, who tried to restrict than removing the stomach fundus, put a band around the proximal part after doing a transection of 3 to 4 centimeters of the fundus. It worked well, but because of a foreign body, it had a lot of complications of slippage, migration, fistulas, perforations, everything happened. Of course, it slowly went down, but it was the most popular until 1990s. And in 1990, gastric band was introduced, which is a modification of the vertical band gastroplasty by Mason. So somebody designed, by name Kushmak and Yap, designed a band which was the most popular throughout the 1990s and the early 2000s. In 1993, diagonal switch was invented by Hess and Markov, and till now it is one of the most popular bariatric procedure, uh, especially as a revision procedure. In 1993, sleeve gastrectomy was first again invented by Markov as a part of a two-stage procedure of a diurnal switch with, bilioperic diversion of the diurnal switch. Uh, the patient had some kind of cardiac and pulmonary issue during this first stage of a sleeve, so they abandoned that and made sleeve gastrectomy as the only procedure in that patient, and the patient lost adequate weight and with least of complications. So that made way for sleeve gastrectomy to be reinvented as a standalone procedure, big time, by Michel Gagner in 1989. After his publications became huge. In 1996, Scopinaro modified the Kremer technique of gastric bypass and Mason's technique of mini gastric bypass, modified together to put what we call as a Roux-en-Y gastric bypass. Uh, that became the gold standard in the early 2000s and still is the gold standard bariatric procedure. Of course, Robert Rutledge in 1992 redesigned Mason's mini gastric bypass into a sleeved gastric bypass, along with that Markov technique, combined sleeve and the Mason technique to form a successful mini gastric bypass, which was slightly modified by Carballo to make it a one anastomotic gastric bypass, which is again the another most popular procedure apart from RYGB and sleeve gastrectomy. So, what are the indications for bariatric surgery? Because plenty of people come to the OPD and in the general public as well have doubts about when to do bariatric surgery. Of course, there are plenty of meta-analysis that came to the consensus by the IFSO, ASMBS, and as well as RC by Indian Association, that we should operate not less than a severe obese. That is a BMI of more than 32.5 is the minimum what we need to look into. 35 for a Western population. Either severe or a morbidly obese patients. If they are non-morbidly obese, then they should have uncontrolled diabetes, which is called as a metabolic surgery. Other severe comorbidities like severe sleep apnea, severe arthritis, infertility, along with morbid obesity, yes, it can be indicated for bariatric surgery. And a failed medical management, of course. Everybody has to try lifestyle management for 6 months. If they fail, then they should look into bariatric surgery as an option. Poor quality of life. Patient is bedridden or not able to move around. Then we can consider a low BMI patients as well for bariatric and metabolic surgery when there is some comorbidity associated with it. So when you want to have inclusion of patients in this procedure, all the patients within the guidelines as mentioned before. And of course, uncontrolled or poor control of diabetes is important, poor quality of life important, and then patient compliance is pretty important as well. We should know, identify. That is why we look into a psychologist who plays a big role in this, who are going to assess the patient, whether the patient will be compliant to the post-operative follow-up period. Because these patients have to follow up regularly, have a lot of nutritional deficiencies which needs to be addressed by our diet changes, lifestyle changes, medications for a longer duration of time, sometimes lifetime as well. So you have to be very careful with those kind of complaints. Otherwise, the patient will have plenty of a poor quality of life post bariatrics, which we don't want because that's a primary aim on which we are going to operate these patients. So, what are the recommendations for surgery? There are plenty of surgeries which come into the market, starting from 19 early 50, 1954 until now. There have been about 25, 30 types of procedures which have come into the market. Most of them have become obsolete, but right now the guidelines by IFSO, ASMBS, where gastric band, sleeve gastrectomy, roux gastric bypass, biopentic diversion, these are the only four that are accepted. Whereas countries like India, Brazil, Taiwan, Korea, we uh, approve other procedures as well. One of the most important procedure which we approve is one anastomotic gastric bypass or the mini gastric bypass. Then RC, very interestingly, in 2016, we, as an executive committee, has decided to allow other procedures which have been published as a novel surgery by an Indian author with similar results comparable to OAGB, namely duodenal bypass and ileal interposition, who have been having a lot of publications from Indian population, for the Indian population have been approved as well. So these are all the recommended procedures as of now. So we have seven recommended procedures as of now by Obesity Surgeon Society of India as per our guidelines. So what are the BMI categories which we agree upon? International Diabetic Federation as well as International Federation for Surgeons of Obesity Asia Pacific chapter has come with a consensus in 2011 where the principal cutoff of 35 and above, that's obesity class 2 and 3, which comes to under severe and morbid obesity, or the surgical indications for the principal cutoff in the Western population, whereas in the Asian cutoff, we started somewhere from 32.5. So what is in the green is the recommended guidelines, and what is in the red is advised guidelines for surgery. So anybody more than 32.5 are eligible for bariatric surgery as per IFSO APC and IDF guidelines. So preoperatively, what will you do? So we will have a regular surgical checkup. Beyond that, we will try to address any hormonal and nutritional imbalance with the patient. So we will do sugar by means of HbA1c, or just simple RBS. HbA1c if the patient has diabetes. Then we have liver function test to see the liver enzymes, how much of a NASH or a cirrhosis they have, lipid profile to find out the cholesterol and the triglyceride level, and AG ratio, protein, albumin, then thyroid profile to see if there is any hypothyroidism, then cortisol and prolactin. There can be some stem cortisol suppression, there can be hyperprolactinemia, and pulmonary function test to rule out sleep apnea as a screening test. If the sleep apnea is indicated in pulmonary function test, then you have to go for sleep studies. Then ultrasound abdomen, yes, to understand gallstones, which is pretty common in obese patients, or any other issues like ovarian cyst, or any abnormality which can be addressed intraoperatively, or we don't want to suppress intraoperatively as well. And UGScopy for two reasons. Reason number one is a reflux, which is very common in these patients. Silent reflux can become a de novo severe GRD, or de novo hiatal hernia can be happening post bariatric surgery. So better to address this early. So identify, even the type of surgery can differ with a hiatus hernia and a severe reflux. Other important finding is again, reason is like a missed gist. There are some accidental gist which are missed in a retained stomach, in a bypass, so that there's no access to the redundant stomach, which makes it a very problematic issue later. Or H. pylori can be identified as well, which can be eradicated well before the surgery, so that we don't have any reflex acidity that can be a problem post-operatively. In diabetes, maybe we'll add C-peptide fasting and prostaglandin as well. And there are other nutrients which need to be addressed as well: B12, iron, calcium, and protein has to be seen as well to understand the nutritional deficiencies. Anything was there before which need to be addressed, or post-operatively to compare what is the type of deficiencies that are coming through. These are again, others are echocardiogram, cardiac opinion. All those things are must. Pulmonary opinion, anesthetic opinion before taking for surgery. So preoperative preparation wise, there have been a lot of discussions on how to go with the liquid diet. But ideally speaking, 5 to 7 days of liquid diet maximum patient can manage. These patients are already obese patients who have some psychological issues and who have some trouble in not able to eat. I mean, in not able to stop eating. So when you give these patients liquid diet for a week and beyond, 3 days, 5 days maximum. Beyond that, they will cheat, and the whole exercise of liquid diet is gone. And the liquid diet is important to make sure that the liver shrinks, the stomach shrinks, the intestine shrinks, so that we have a better space and better availability of bowel for us to operate. Because there are plenty of momental cake of fat which is disturbing, going to disturb your surgery. So getting the or the most shrunk liver and intestine and stomach is pretty important to the success of the surgery. Of course, pulmonary exercise is very important for all the people. Incentive spirometry is given to get them with to improve the lung capacity and decrease the retention of carbon dioxide for people with sleep apneas. And CPAP is a must for anybody with sleep apnea, and BiPAP for patients who are already on CPAP. And cardiac evaluation should have an ejection fraction of 40% in the echo, which is important. Less than that, people have to be optimized before taking for surgery. DVT prophylaxis is very important. There are plenty and plenty of discussions and debates on it. What kind of a DVT prophylaxis is good? So, in DVT prophylaxis, we commonly follow a sequential compression device from the immediate pre-operative period until 24 hours post-operative. The patient is ambulant. For all patients, is a highly recommended, or what we call as a guidelines for bariatric patients. Then there are some variations in the further prophylaxis using low molecular weight heparin. No, some use, some don't use, but the guidelines clearly says we have to have at least 2 doses of heparin, one pre-operatively and 3 doses, and two post-operatively, minimum of low molecular weight heparin to make sure that DVT doesn't hit the patient. If the patient has previous history of DVT, then these patients should continue for at least 2 weeks, and previous admissions and treatment for DVT needs to have for a month. And IVC filter might not have too much of an advantage. So continue with DVT, low molecular weight prophylaxis for a month for this kind of a patients. Of course, metabolic and endocrine optimization, thyroid has to be brought down. If it's 10, 12 total, thyroid stimulating hormones, it has to be brought down below 8, ideally to take up for surgery and to make it optimized for that. And for bowel preparation, as I told you, by liquid diet is one preparation. Other preparation is we give Exelite or some enema or peg leg to make sure that there is nothing in the intestine. But there are controversies about them helping, not helping. But in our unit, we follow Exelite 90 ml the night before surgery, before putting them NBM. That helps a big time in compressing or collapsing the whole small intestine for us. Come to principles of surgery. There are three basic principles: reduce ingestion, decrease assimilation, and lessen your desire. So, restriction, malabsorption, and satiation. These are three principles on which it works. Restriction by restricting the stomach size, malabsorption by adding a bypass, and satiation because you remove the fundus of a stomach, the ghrelin hormone is knocked off, which helps in satiation, which we'll come to a bit later. So it works on three theories, bariatric surgery. One is called the Foggett theory. What does the Foggett theory say? In a normal GI tract, ghrelin is secreted by the stomach, mostly from the fundus and a little bit from the body of the stomach. That triggers the duodenum to secrete a group of hormones called incretins. These incretins are a group of hormones which include GLP-1, GAP, PYY. So GLP-1 increase and GIP decrease. That is, this helps you to control your sugar secretion as well as increase your satiety. And since majority of stomach is removed in a sleeve gastrectomy and a bypass, the nutrients passed rapidly into the proximal GI tract, decreasing early decreasing. Earlier the ghrelin secretion is less, causing less activity of the anti-incretin hormones, which resists the incretin group of hormones, that is GLP-1, GAP, and PYY. Also, indigested food particles come into contact with the small bowel, that immediately reduces the appetite. So both the secretion of anti-incretins as well as the ghrelin reduction and undigested food particles getting into the small bowel, they have a detrimental effect in the digestion. So reduced digestion, reduced appetite will happen, and that helps in weight loss. And because of the resistance hormones of anti-incretin not being secreted much, the GLP-1 increase and PYY increase will cause something called as a improved glucose tolerance. That is, the resistance to secretion of insulin is reduced. So these people will improve their insulin secretion, causing control of diabetes. So there are few procedures which are strong in the foregut option: a gastric band, a sleeve gastrectomy, and a Roux-en-Y gastric bypass partially. 80% restriction and still 20% malabsorption is a part of uh, uh, Roux-en-Y gastric bypass. So this is called the forget theory. So ideal candidates are severely morbidly obese, associated comorbidities, volume meters, and sedentary lifestyle people. In a sleeve gastrectomy, ideally what we do is the omental dissection is happening. Remove the greater momentum, detach the greater momentum from the stomach. Then add hiatal dissection to make sure that the angle of his is relieved of the all the ligamentous attachments, especially the gastroesophageal attachments, as well as the gastrophrenic attachments in the proximal part. Once the dissection is done, the whole retrogastric space is devoid of adhesions as well. Then the stapling happens from 2 to 4 centimeters lateral to the pylorus. Beyond 4, there's a high chance of recurrence or reduced weight loss. So 4 is the maximum breakage point. It used to be 6 centimeters before, now it's around 4 centimeters. Start the first stapling and create a vertical staple, leaving 1 to 1.5 centimeters of angle of his, the fundus of a stomach close to the OG junction, leave them behind in the sleeve so that the vascularity is not compromised, because there is a end vessel communication between the esophageal branches and the gastric branches in the esophagus. So too much of a dissection can cause vascular compromise, and leak is pretty common. So these are the attachments which need to understand while doing a sleeve gastrectomy. One is called what called as a you know the phenoesophageal ligament is very important in understanding this. But when you start having a sleeve gastrectomy done, we'll go from the lateral part of the momentum. So once you get close to the gastrosplenic area, then we encounter the short gastric pedicles. So transect the short gastric pedicles, then get into the gastrosplenic ligament, which is just above that. So the gastrosplenic ligament, if you release, then you get into something called as gastrophrenic ligament, which is close to the angle of his. And a little bit of a gastroesophageal ligament also has to be sacrificed on the left crural side. So what happens with this is the whole stomach fundus is released. Otherwise, the fundus will not be released. And if the fundus is not released, then you let go of a posterior fundus a lot, which leads to inadequate weight loss or a earlier weight regain. So, most important, gastrosplenic ligament, gastrophrenic ligament, and left side of the phrenoesophageal ligament, all three has to be sacrificed in a sleeve gastrectomy. Then, another important thing you understand is gastric wall anatomy. You all know that stomach is made up of longitudinal muscles, oblique muscles, and circular muscles. So, anticut antrum. Of course, we are not going to involve the antrum at all. The problem is when we try to retract the stomach to do a stapling, we don't know whether the longitudinal muscles are more stretched, or the oblique muscles are more stretched, or the circular muscles are more stretched. So, when you retract it more and do stapling, when a different level of muscles are included in the stapler at different firing, there will be zigzag firing, which leads to leak later and stricture later. So we have to be very, very careful in handling the gastric wall. So while using the staplers, we should know which staplers to use. The fundus ideally is 1.6 mm thick, and the antrum is around 3.1 mm thick in a normal people. So it can go up to 4.5 in the antrum and 2.2 in the fundus. So depending upon the thickness, which is average thickness of 3.1 at the at the antrum. So we will try to work around a staple which is around 3.8. So normally we use gold, sometimes green in the antrum. The more proximal you go, the stomach becomes thicker. So that's when you start having a blue stapler. You see the green stapler has a height of 4.1 and a gold stapler has a height of 3.8. So when you talk about a 3.1 average, it holds good. In a revision case, the stomach wall is thick, which is going to be 4.5. That is why we use black in the antrum in a revision stomach. So clear, either green or gold in a virgin stomach in the antrum, move towards blue, which is about 3.5 centimeter height. And again, white can be used, but white is so thin, sometimes it can crush, and sometimes the stomach can be thick as well. So we end up using green or gold for antrum, followed by blue for the sleeve. When you talk about revisions, black or green at the antrum, followed by gold or blue from the body and the fundus of a stomach. If you don't do this principle, what happened is the stretch of the muscle will not be good enough, so it will break. It will have a fracture, causing break in the muscle, which can cause leak later. The another thing you need to understand is the gastric pressure. When you do a sleeve gastrectomy, already a high pressure system of 11 to 26 millimeters of mercury in a resting stomach and a filled stomach of 21 to 45 becomes almost double when in a sleeve stomach. The resting can be not much, but a filled sleeve stomach has pressure of 32 to 58, is at least 1.5 times more. That can increase the pressure, that can lead to more chance of leak, more chance of reflux. So, but the principle of sleeve hysterectomy is high pressure system, what we call as a Percival's law. So jet effect, where the high pressure with the opening of the antrum, very high pressure food enters into the uh, small intestine like a jet and forces itself with a faster transit, so making a undigested food go into the small bowel faster transit than before, leading to early satiety and control of metabolic syndromes as well as diabetes. So that's how sleeve gastrectomy is, though a restrictive procedure, help like a malabsorptive procedure as well. So advantages of a simple technique: no major nutrient deficiencies, better patient compliance, excess weight loss of 60 to 70%, and resolution of comorbidities of 65%. Pretty good procedure, but also has a flip side. Complication of 11.3%, major complications 2.5, major becoming leak and stricture, and minor 8.8%. Most commonly reflux and nausea, vomiting, and GRD, as I told you, and a failure of 20%. That's a pretty high compared to other procedures, but still it's good because of the safety of the procedures, what is involved in this. A weight regain of 30% in 5 years is again on the flip side. So you have to be careful about choosing sleeve gastrectomy. So yes, choose this procedure for young individuals who are less than 40 BMI. It helps much better for these patients. Then comes the Rowan-Way gastric bypass. The technique, what we do in Rowan-Way gastric bypass is we have uh, what we call as a lesser curve arch of the vein. The venous arch in the lesser curve, we go below the first or below the second arch. So used to be below the first arch initially. Now it's below the second arch because a long slender gastric pouch is created in RVGB nowadays, which the volume is close to around 25 to 25 cc. Used to be 80 cc in a sleeve gastrectomy, whereas in RVGB is 25 cc. So do a transection, make a small, longer, slender pouch. Then the rule loop is taken 75 centimeter from the DJ flexure. That is anastomosed to the stomach, and the what you call as the afferent loop or the biliopancreatic loop. That 75 centimeter of biliopancreatic loop is attached 150 centimeter distal to the GJ. So the what we call as an elementary loop, that is the anastomotic segment between the stomach and the jejunum until the biliopancreatic limb joins it is 150 centimeters. So 75 centimeters of biliopancreatic limb joins the small jejunum at 150 centimeter from the gastrojejunostomy end. So they make a Rowan Y with a 225 centimeter bypass normally. So this is a typical one-way gastric bypass. But there are plenty of modifications of 100 centimeter of biliopancreatic limb, 150 centimeter of biliopancreatic limb, and alternatively reduce the size of what we call as a elementary limb from 150 to 75 centimeter as well. So the common channel remains the same. 2.25 centimeter, meters of small bowel is compromised. The common channel remains the same. So bypass stapling wise, the gastric stapling I already discussed with you. In bypass stapling, we will add the small bowel stapling. So anatomical wise, DJ flexure is a landmark, 6 meter in length, 2.5 meters jejunum to make sure that the bypass stays within the jejunum. So 200 or 25 centimeters of jejunum is still left behind in the common channel so that we will not have too much of a nutritional deficiency. Ileum is around 3.5 centimeters with 2 centimeter diameter, but the thickness is not that much. It's only about 1.6 to 1.8. So a blue stapler or a white stapler is good enough for small bowel. Since we want to be on safer side, we always use blue staplers for a small bowel. So gold or green for the stomach antrum, blue for the body and fundus, and blue for small bowel is what we normally use in a bypass. Black for a revision antrum. That's the difference what we're going to do. So the advantage is rural gastric bypass is used for all type of eaters. Excess weight loss of 70 to 80% is much better than a sleeve gastrectomy. Restriction of comorbid is up to 83%. That also is higher than sleeve. Again, weight loss, long-term weight loss of 30, 40 years has been reported in this kind of a surgery, whereas the weight regain is little bit more common in a sleeve. And the resolution of diabetes, hypertension, and dyslipidemia are much better with gastric bypass. On the flip side, complications are much more than sleeve gastrectomy. The major complications are 4.1%. Most commonly, leak and internal hernias are pretty common. Minor complications, again, like discomfort, vomiting, nutrient deficiencies, are around 7.4%. Failure is 15% as compared to 20% of sleeve, and weight regain is 20% as compared to 30% sleeve, and 30% weight regain in 5 years in a sleeve, whereas 20% weight regain in 10 years in a bypass. So that makes it a much more durable procedure than the sleeve. That's why it's called the gold standard, which least amount of nutritional deficiencies. Then you have something called as Hindgut theory. What do you mean by Hindgut theory? Hindgut theory is when the undigested food particles get into the distal small bowel, the L cells of the proximal large intestine and the ileal part of the small bowel secrete more PYY and GLP-1. And again, as I told you before, the increased secretion of GLP-1 and PYY reduces your appetite, causing weight loss, and improve your glucose tolerance. So a hindgut theory adds to the foregut theory more. So any procedure that has both foregut, I mean foregut plus a hindgut, definitely is going to be much more stronger than the simple foregut theories. So this is useful for more stronger weight loss and longer weight loss as well. So what are the strong hindgut options? We have one anastomotic gastric bypass. We have duodenal bypass. These two are very strong hindgut options. The one anastomotic gastric bypass is more popular, whereas the duodenal bypass is not as popular as uh, one anastomotic gastric bypass or RVGB or a sleeve. So the ideal candidate, again, a morbid or a super obese, when the patient is very, very obese, it's a beautiful procedure. Again, it can be for normal eaters as well, because the nutritional or the hormonal changes are much more commoner than the restriction alone. So it can be for even for normal eaters. And of course, the patient complaints is important because of nutritional deficiencies that come along with this. In a OAGB, what we do is a pouch is created, contrasting to 25 cc pouch in a RVGB, we create a 80 cc pouch here. When you create 80 cc pouch, you have to be a bit careful because the 80 cc pouch has to be a longer pouch, as we are going to do a loop bypass, whereas it's a room one way bypass. The biliopancreatic limb is completely diverted 150 centimeters beyond the stomach. Whereas here, since the bile is going to come back into the stomach because of a loop bypass, the longer the pouch, the better the chance of not getting a reflux. So it should be a slender, longer pouch. Ideally speaking, the pouch should end below the level of the transverse colon. So your transaction has to be below the nerve of jet or the crow's feet and just above the antrum. So that gives you a good long length of a pouch. Then take 150 centimeter or 200 or 250 or 300 depending upon what is the length you wanted. But again, beyond 200 it's not safe because of the nutritional deficiencies that come along with it due to the dumping syndrome and the sacrificing more than 200 centimeter of a jejunum. So take them and then do a GJ at the end to side anastomosis. There is a small modification by Carvalho where he adds an anti-reflex suture where you take the biliopancreatic limb bit up and attach that to the body of the stomach. So the bile goes up to the body of stomach and drops down into the anastomosis. So that way, uh, anti-reflex suture is created, and that's called one anastomotic gastric bypass technique by Carvalho. So advantages include simple alternative because one anastomosis only, as the name indicates. Excess weight loss similar to gastric bypass. Resolution of comorbidities can be more than gastric bypass because of a lot of nutrition. Metabolic effect because of the hormonal imbalance and the nutritional effect are more. Dumping happens in this procedure very commonly. So these adds to the weight loss and the resolution of comorbidities much better. Of course, patient complains better because of a bigger volume, 80 to 100 cc of stomach is left, so patient can eat better in this. Failure rate is about less than 5%, which is pretty good, which is 10% in RBGB and 20% in a sleeve. The disadvantages of complications has a least amount of complications compared to all three, sleeve, bypass, and OIGB. And the major complications are very less, 1.2%, very less chance of leaks in OAGB because of a wide anastomosis, easier operative technique. Minor complications, although are less, but the bile reflux is a major issue and nutritional deficiency is a major issue. If we don't replace nutrition properly, these people have a lot of protein deficiencies and other nutrition deficiencies. And bile reflux sometimes can be interactive where we may have to undo the procedure or divert the one anastomotic gastric bypass. Long-term results, now we have about some 18, 20 years of results, but still is not at as long as RYGB. So that's why it's not still been accepted big time as alternative to RYGB in most of the countries. And the third method of weight loss, the third principle is ileal brake theory. Ileal brake theory works simply on indigested or undigested food particles coming into the contact of ileum. Sudden surge in increase in PYY reduces appetite straight away and reduces secretion of ghrelin as well. So your hunger is lost, satiety is improved satiety. The multiple theory options, foregut, hindgut, as well as the ileal brake theory. There are two procedures which use this. One is ileal transposition, second is pancreatic diversion. So these are all the most strongest of procedures available in practice now. Ileal interposition is not very popular because of its complexity, where we take 100 centimeter of ileum, transect for 50 centimeter from the IC junction, and again proximally measure 100 centimeter. That 100 centimeter of ileum is interposed in the proximal jejunum as a conventional ileum. Interpose it to the duodenum as a diverted ileal interposition. So basically, you have a sleeved stomach, then duodenum, then ileum, then jejunum, then ileum again. So interpose a section of ileum into jejunum or into the duodenum, causing ileal interposition. So what happens is the foregut theory works, the hindgut theory works, and ileal break theory also works. So it helps in a good way because of the complexity and because of post-operative complications of constitutional symptoms and too much. This is not highly popular. Biliopancreatic diversion is again because here we anastomose the biliopancreatic limb to ileum, so the undigested food particles get directly into the ileum. So bypass happens, foregut hindgut theory works because along with the sleeve, and then ileal break also happens. But the problem again is nutritional deficiencies are so severe. This has been modified now to 250, 300, 350 common channels, but the weight loss becomes as common as a RVGB and an OAGB. So these modifications keep happening. There are plenty of novel procedures can keep coming, but still BPD and ileal transmission forms the least amount of surgeries in the available market now. Then we also call as a metabolic syndrome X. We all know obesity because of excess adipose tissues. The triglyceride storage is too much, and then the breakdown of triglyceride leads to overabundant circulating of fatty acids, causing obesity. And this increases the fatty acids, gives insulin resistance and diabetes. At the same time, it increases the liver triglyceride synthesis and production of low density, lipoprotein, and then hypercholesteremia happens. This insulin resistance also lead to loss of vasodilatation and preserves the sodium absorption and causes hypertension. So obesity in per se causes these three, or the metabolic syndrome X. How it helps? What we call as the enteroinsular axis. The ghrelin increases secretion of anti-incretins, which is given in the dark black dots. Incretins are the white dots. Incretins are GLP-1, GIP, and PYY. Most likely GLP-1 increase. Anti-incretins gives resistance to secretion of that. So what happens is because the anti-incretins reduce the secretion of insulin, incretin, there is a resistance to secretion of insulin, so delayed insulin response and impaired insulin action, causing diabetes. This is called enteroinsular axis mechanism. So if it's too much of anti-incretins, you develop diabetes. If it is too little of anti-incretins, then you will have dumping syndrome. The same two concepts of dumping syndrome and type 2 diabetes and incretins decrease are used as a benefit in metabolic procedures. So what they do is, if you do a sleeve, the ghrelin is reduced because you remove the ghrelin part of the stomach. So the secretion of anti-incretins are lower. So there is a better control of sugar because the incretins are secreted better, less resistance to the uh, uh, incretin secretion. If you do a bypass, since the bypass the entire region of the small bowel, that is approximately 80 centimeter of jejunum, where the anti-incretins are secreted, so the anti-incretin effect comes down by 90%, which can easily normalize the sugar because of this, because the incretin is secreted throughout the small bowel, whereas anti-incretin in the proximal part of small bowel. And that's why we recommend bypass to any patient with a metabolic syndrome and not just sleeve alone. So resolution of diabetes, 9% of all and 32% of obese population has diabetes, and 95% of diabetes is type 2. So resolution at 5 years after bariatric surgery can be between 93 and 98% if it's less than 10 years. More than 10 years, it can be lesser, 70%, 80%. So 83% resolution after 10 years with a meta-analysis, and 100% resolution of complications. That's a very good point to take home, because you avoid retinopathy or a neuropathy or diabetic foot kind of scenarios when you do a bariatric surgery in an uncontrolled diabetic patients. Comes to hypertension. As I told you, increased GLP-1 reduces the visceral fat mass and intra-abdominal pressure, as well as improves the insulin resistance and endothelial function. This decreases the renin, angiotensin, aldosterone system activation, and reduction in the sympathetic nervous activity, but that's by decreasing serum leptin and increasing post-operative, uh, you know, uh, uh, natural disease. So This reduces the completely brings down the hypertension, and of course other mechanisms are reduced food intake and such way, and with it salt intake as well, and dumping syndrome causing some high osmolality substance like salts, and restoration of endothelial function as well along with it. So plenty of actions happen to reduce hypertension in a bariatric patient. And again, when it comes to hypertension, 17% of all and 37% of obese patients are hypertensive, and 49% patient is diabetic and dyslipidemic with their hypertensive, and 64% resolution after bariatric surgery, as high as 93% if the metabolic syndrome X is there. If sugar, BP, cholesterol are together, 93% chance of becoming non-hypertensive, and 83% decrease in the cardiovascular accidents. That's a very high number of cardiac arrest being avoided. Another important is a non-alcoholic fatty liver disease. So how fatty acids are maintained? So bariatric surgery decreases the weight, decreases the vascular adipose tissue, thus decreasing ghrelin, and increase the bile acids, and thus decreases the insulin resistance and increases insulin sensitivity, and also decreases the CRP, TNF, alpha, LDL, HDL is increased, total count is decreased. So plenty of happen, and then leptin is decreased, adiponectin is decreased. So this kind of a complete change in the bile acid kinetics reduces the cholesterol absorption and potentially treats non-alcoholic liver disease. 14% of all and 30% of obese has dyslipidemia. 79% had some abnormal lipid parameters if they're obese. 63% resolution after bariatric surgery, and up to 96% if they have metabolic syndrome X. And of course, 65% resolution of non-alcoholic fatty liver disease, that avoiding cirrhosis because of obesity. The another common thing is a polycystic ovarian disease. So hyperandrogenism and will decrease the androgens and increase sex hormone binding globulins and decreases the hirsutism. Metabolic syndrome effect of decreased insulin resistance, decreased diabetes and gestational diabetes as well, decreased hypertension also helps in reducing the polycystic ovarian disease. Then again, lower BMI, decreased leptin, and again, restoration of menstrual function all improves the polycystic ovarian disease put together as a multi-factor. 30% of all and 65% of obese women have polycystic ovarian disease. 50% of PCOS patients are infertile, and 17% resolution of secondary sexual characters. That's a beautiful one when especially comes to infertility. 100% resolution of menstrual disturbance and 70% reduction of infertility. That's pretty high percentage of resolution of infertility. Even an artificial insemination or IUI or IVF gives only 60 to 70% resolution. The similar resolution is given in infertility by bariatric surgery per se. And there are some ideal metabolic surgeries which we recommend. RVGB being the gold standard, OAGB is the most popular as of now, and duodenal bypass, where it avoids the controversy of a OAGB but has a result of a RVGB because of its complexity, still not popular. As I told you, BPDDS, due to their nutrient deficiencies, is not very popular. IT, not popular because of the complexity of the procedure as well. So these are all the ideal metabolic procedures. There are other mechanisms which help as well. One is called gut microbiota. MATE and interleukin 17 are two important factors which need to understand. In obesity, there are plenty of change in the gut microbiota. We have Enterobacteriaceae, Clostridium difficile, and bacteroids, which are very common, which will increase the inflammation. So there is increased inflammation in the blood, increased secretion of interleukin 17, and reduced mate cells because of this bacterial colonization, and this increases the proliferation of adipose tissues, and cell death is decreased as well. In a lean individual, the gut microbiota has Staphylococcus, Streptococcus, Lactobacillus, and Bifidobacterium. So Lactobacillus and Bifidobacterium are more of a probiotic and prebiotic, bacteria. So which increases the mate cells and decreases interleukin and decreases inflammation of the blood, as well as it decreases the proliferation of adipose tissues and cell death, causing to maintaining the lean mass. So there has been a link between the bacteria colonization within the stomach and obesity as well, and that is why plenty of deworming and prebiotic probiotic addition helps in weight loss. Then what is a slimmer effect? So since you do a bypass, there is a longer route of bile transit before it enters the stomach and helps in digestion. So what happens is disruption of the enterohepatic circulation elevates the plasma bile acids and its subfractions. This is linked to cholesterol homeostasis and critical assistance of the gut microbiota. Along with it, increases the energy metabolism and improves the lipid and cholesterol metabolism, causing NFALD as well as weight loss and improved glucose tolerance and increased satiety. So all this is because of a slimmer effect by the bile acid and bile salts longer transit. So these are all two different mechanisms which has been added to it. That is why the weight loss is different from different individuals based on the gut microbiota as well as slimmer effect as well. So the more bypass we do, the more effective it is. Butchwald did a very beautiful log scale meta-analysis on the metabolic syndrome part. Restriction diabetes around 84% with bariatric surgery, but with a diabetic medication still is 67% only. Same with hypertension. Medications can lead to 62% resolution, whereas surgery by itself 79% resolution. Sleep apnea reduced by 58 with medications and other exercises, 86% with bariatric surgery. Dyslipidemia 65% with medications and 72% surgery. So surgery per se without any medications have much more beneficial effect than the medications. That's why we look into more of eradication of metabolic syndromes by bariatric surgery. Other outcomes, of course, cardiac diseases comes down, risk comes to 82%, joint arthritis comes down by 76%, acidity comes down by 98%, asthma comes down by 98, 82%, and of course, polycystic bone disease reduced by 100%, urinary incontinence is very common in women, which is reduced by 88%, migraine, most of the people have migraine, which is reduced by 57%, depression, again, depression runs in bariatric patients, 50% is depression, gout in 77%, and venous stasis causing chance of DVT and other things reduced by 95%. This gives a quality of life improvement by 95% and 10 to 15 years gain in life expectancy. That's pretty high number, and that is why bariatric surgery has been talked about and debated so much in the last decade. In the post-op period, liquid diet for a day, normally we give 6 times a day, and then puree diet for 2 weeks, 6 meals a day, two proteins and four puree along with it. Soft diet until 3 weeks, so six protein rich meals a day and two snacks, and then normal diet from 4 weeks. So liquid diet of 60 liquids of 60 minutes before or after food is prescribed in this kind of a post-operative diet period. And follow up, we follow them up after surgery at 1 week, 1 month, 3 months, 6 months, and 12 months, and then 18 months we'll see where what we call as a nadir. Nadir is the plateau of weight loss happens by end of 18 months, and expectation of 4 to 10 kilos weight loss per month depending upon the amount of weight these patients have. Of course, regular nutritional checkup is important. Skin and muscle toning exercises are very important to avoid the sagging of skin, and additional procedures of cosmetic surgery sometimes can be necessary. Pregnancy, I have to wait for normally 18 months to 24 months before the nutritional deficiencies are managed. But very important is a nutritional consideration. Since the stomach has a lot of absorption of B12 and iron, and small bowel, especially proximal small bowel, has plenty of absorption of protein, folic acid, calcium, A, D, E, K, vitamins, B12, and some water, and more water in the and sodium, as well as distal small bowel having water absorption as well. Bypassing these things definitely have some kind of a nutritional implications. So, as per the IFSO and APC and ASMBS guidelines, 17 to 41% of people have deficiencies. Protein, iron, B12, and calcium have to be definitely replaced. And vitamin B1, B2, A, D, E, and K are also has to be replaced if possible. That's why We give a post-bariatric multivitamin pill which has a higher concentration of all the multivitamins and nutrients to make sure that patient doesn't fall under the deficiency category. Of course, at the end, what is the ideal procedure? It should be nutritionally safe and is durable. Sleeve gastrectomy and root gastric bypass are the most nutritionally safe procedures. Duodenal bypass and one anastomotic gastric bypass are not that safe, but intestinal bipartition or the latest techniques are not great when it comes to nutritionally safe procedure. Durability wise, root gastric bypass is durable, but one anastomotic gastric bypass and duodenal bypass scores much over the nutritional bypass, whereas bariatric diversion have not durable as well. So, a combination of a sleeve, root gastric bypass, and one anastomotic gastric bypass, or duodenal bypass, are the safe procedures to be done in bariatric patients. It's a very interesting study. I saw a position statement 2016 comparing bariatric and gastric surgical data, what we call as a GA literature data, the literature index. The complication of uh, GI surgery is 17%, whereas national data of our obesity national society is 7.4. IFSO data is 8.7 for bariatrics. So when compared to GA literature data, bariatric data has half the amount of complications. So the whole idea of telling bariatric surgery is more complicated, it is very dangerous, is wrong when compared to the GA data. Same way with mortality. 3.15 is the mortality of a GA literature data, whereas bariatric data says less than zero point 0.3 in Indian data and 0.45 in the international data. So comparing both the complication as well mortality, bariatric scores high over the gastric surgical data of the GA procedure. So it is one of the safest GA procedures ever done in the world. So the whole idea of putting bariatrics down because of the complications of the surgery is a wrong myth. There are three available techniques: laparoscopy, single incision laparoscopy, and robotics for this. You can choose between whatever technique you wanted. Of course, laparoscopy is pretty commonly used, easy, sills only on special indications and in an experienced hands to be used. Robotic is a very easy step between uh, open surgery and laparoscopy, where the minimal access can be learned much easier. So if a surgical center has robotics, much easier to convert yourself into a bariatric surgeon than laparoscopy. And novel procedures are procedures which have been commonly used in the recent 1 or 2 years are a banded bypass, a sleeve gastrectomy with a proximal jejunal bypass, giving a long uh, you know um, uh, loop of intestine, uh, which is controversial because they say uh, uh, a long dead loop can cause a lot of bacterial colonization. But theoretically speaking, yes, but practically it's not happening. So um, proximal bypass has its role as well. What we call as a SADI, single anastomotic duodenal is a modification of duodenal bypass. Instead of a jejunum, you put the ileum for this. So this is a modification of DJB as well as biliopancreatic diversion, which is holding good as a revisional procedure right now. Another procedure is gaining popularity is SASI. They do a sleeve and then do a bypass in the sleeve itself. So you do something like a duodenal bypass or a one anastomotic gastric bypass, but instead of transecting the antrum, you leave a sleeve and anastomose in the antrum. So becomes a much more easier procedure to do than TJB or a SADI. But however, the results are yet to be appreciated in a long run. Then we have endoluminal bariatric surgery, which has recently come up into the practice, still evolving, primarily for a gastropexy, where we do something similar to sleeve, and a revisional is stromal reduction, and useful mostly for metabolic surgeries. Another interesting bariatric is a procedure is an intragastric balloon. So weight loss of 45% excess weight loss is happening in the balloon, but 25% of failure rates is there. 4% major complications of perforation and obstruction of the balloon getting blocked, but minor complications like nausea, vomiting, because of impaction and ulceration and other. 7% area explantation is common in these patients because of the constitutional symptoms, and longer the implant, greater the weight loss. Best for moderate to severe obesity, up to 20-25 kilos weight. Again, in our series, we had 6 months balloon and 1 year balloon, uh, called the spat balloon, and 6 months the Orbera balloon are used. So excess weight loss of 46% if a 1 year balloon, and explantation is only 2% in our series, with severe nausea of 12%, and a complication of one patient having the balloon burst. And once in a 6 month balloon, we had to remove it endoscopically. In a one year balloon, the patient passed the balloon through the natural orifice, which was a very alarming thing. But somehow the patient didn't understand the balloon burst, and she did have motion having the balloon when she passed it 2 days later. Primary endodontal procedures is called as endoscopic sleeve gastroplasty. There are various companies. One is Overstitch company, and another is a Stomafix company, which has been into the market. But Stomafix is gone out of picture now. Endoscopic sleeve gastroplasty is the only one that has come into still in vogue, and this is doing a two-layer of closure of the greater momentum. A greater curvature of the stomach, making it a small, slender sleeve kind of a pouch. We have a series of 4 cases, and our complication is nil. Operating time of around 45 to 30, 50 percent, minutes, and average weight loss of 12 kgs in 1 year. So this is basically done for patients around moderate to severe obesity, 15 to 20 kilos overweight. For the kind of patients is much helpful. Revisional endoscopic bariatric surgery for enlarged stoma post RVGB. If the stoma is too big, patient can gain weight because of what we call as a candy cane. That the stomach already is wider because of the stoma, and the small bowel jejunum also widens to become a neo stomach. So this needs to be avoided. So for suturing the large stoma, and sometimes gastrogastric fistula post sleeve or post bypass, and sometimes the dilation of the pouch, otherwise what we call a the gastric fundus dilatation, can be used. So as well as some kind of in the anastomotic stricture, you can uh, lay open the stricture and suture that as well. So the overstage stromal reduction normally happens by reducing the stromal entry, and we have experienced 2 cases, excess weight loss of 6 years. So complication is nil. So we tried this for post RVGB patients, where we avoid revision surgery for the patient for weight regain. And other endoscopic newly coming into the market is endo barrier sleeve or endo sleeve, where we pass in a small PTFE sleeve through the endoscope, and this sleeve is around 80 centimeter in length. We have fixation of the sleeve to the antrum, and the PTFE sleeve goes to 80 centimeters of the small bowel. So whatever food that is consumed will go through the sleeve for the first 80 centimeter of the small bowel, which is where the anti-incretin is secreted. This helps avoiding unnecessary contact of the food to the proximal bowel, reducing the effect of anti-incretins, thus controlling the ghrelin secretion as well. So this way, there is a 30-40% excess weight loss is eligible, along with resolution of comorbidities by 40-50% as well. Then another one is a duodenal mucosal resurfacing. Since they say a lot of anti-incretins start secreting in the duodenum, and the most amount of ghrelin secretion trigger happens in the duodenum. So resurfacing of duodenum helps reduce secretion of ghrelin, as well as increase the decrease anti-incretin secretion as well. But the problem with it is the weight loss happens pretty good. About some, resolution of comorbidities happens pretty good, about 30%. However, uh, the growth of the resurfaced mucosa uh, happens and the patient fades beyond 1 to 2 years time. So that way, it's still in the evolutionary phase. When it comes to the Aussie or national thing, in 2019 we had a study of the entire data of bariatric surgery. We had some 20,242 procedures, of which 44% of them are sleeve, and 31% are one somatic gastric bypass, and 22% of RVGB in our series. And of course, our data, we have done close to around 146 patients in 2019 with the resolution of comorbidities similar, and excess weight loss is similar to the overall national data as well. Uh, and we did a small study comparing sleeve with RVGB and OAGB. Resolution of weight is pretty good in all the three, though OAGB has much more BMI loss and weight loss as well. HbA1c is much reduced in a bypass technique, and OAGB has much stronger resolution of sugar. Dyslipidemia, again, it's similar in all three, but OAGB had much stronger one. B12 deficiency, iron, calcium, and protein deficiency are least in sleeve, okay in RVGB, and much more in OAGB. So, technically, stronger procedure, good results, but nutrient deficiencies are common in OAGB than sleeve and RVGB. Our resolution wise, 86% resolution of diabetes, 91% hypertension, 78% dyslipidemia, 81% sleep apnea, 71% arthritis, and 90% infertility. That's a very high number of resolution of comorbidities in our series of 2,500 cases. And in national trend wise, number of surgeries, it used to be gastric banding very much in the initial 2014, and sleeve was about some 7,000 sleeves in 2014 compared to 9,000 sleeves in 2018. OAGB was close to 1,514, and now it's 7,000. So OAGB has been growing phenomenally well, whereas RVGB is a bit more stagnant from 1,000 to 2,000 in 2016, and from 2016 is somewhat similar, around 2,800 to 3,000 RVGBs. Other procedures are very, very less. So comes to percentage of share, 48% of share in 2019 with sleeve, and 31% with OAGB, and 15% with RVGB. So to end, we formed an algorithm based on Himpens for bariatric surgery. If the patient has a reflux or hiatus hernia, then do a bypass. The bypass can be RVGB, OAGB, or DJB, any bypass what you wanted. If the patient is less than 40 BMI or more than 40 BMI, it's the same. If the patient doesn't have a reflux or a hiatus, if the patient has diabetes, then do a bypass. In certain cases with less than 40 BMI, we can look into a sleeve also as an option. If there is no diabetes and they are binge eaters, then both sleeve and a bypass can be tried. When they are sweet eaters, bypass is the first choice and sleeve as a second choice for patient with BMI less than 40. If the patient is BMI more than 40, look into bypass. If they are volume eaters, less than 40 BMI, still sleeve can be managed. More than 40 BMI, bypass. So this is an algorithm for bariatric surgery. Comes to metabolic surgery. If the patient is obese and diabetic, class 3 obesity, recommended metabolic surgery. Class 2 obesity, optimizing the lifestyle changes. With a poor glycemic control, metabolic surgery. With a good glycemic control, consider metabolic surgery. Otherwise, continue with the lifestyle changes. If a class 1 obesity, poor glycemic control, consider metabolic surgery. Good glycemic control, non-surgical treatment. If they are non-obese and diabetic, consider non-surgical treatment. See, this is an algorithm for diabetic patients. To conclude, bariatric surgery gives the best long-term weight loss and improved quality of life. Only modality available for long-term resolution of uncontrolled comorbidities when the lifestyle management fails. Mechanism of weight loss helps to choose the right procedure to do a bariatric as well as metabolic procedures. Weight independent diabetic resolution aids in ideal metabolic surgery. For these reasons, a metabolic surgery has to be carefully chosen. Multidisciplinary approach is very important, and referral system helps in long-term success and least amount of complications as well. Thank you. Hope you enjoyed the show. Bye all.